Hello everyone. This is in continuation of the series of chest X-ray basics for undergraduates. In the part 1 of this video, we have studied regarding interpretation of a normal X-ray, and now we will be seeing pathological X-rays, right? So we have discussed all these things about normal X-ray, and now today we will be discussing regarding a pathological X-ray, an X-ray which is very commonly given in your exams. So first of all, describe this X-ray in the A, B, C, D, E, F approach, right? This is the approach. A is for the airways. It is the major airway, trachea, dividing into the right and the left main bronchus. Can you see that the trachea is divided is shifted to this right side? This is of course a PA view, definitely. And what you see in the bones, let us see the bones. These bones are all right. So A, B, so everything, whatever bones are being visible here, we will have some overview of it. The cardiac cell, we cannot see the heart shadow here, rather something is being very much visible. The right heart border is somewhere here, which is not the usual location. And now the diaphragm, the right hemidiaphragm is visible, the angle is clear, but the left is not at all visible. And in the lung field, I do not know what it is, but this is a homogeneous opacity obscuring my lung field on the left side, and it has got a meniscus like upper border of the fluid with the highest level somewhere at the axilla. So what do you make of it? This is the homogeneous opacity causing some pushing effect to the mediastinum. The trachea has been shifted to this side. The heart has also been shifted. The angle, there is a meniscoid like thing with the upper border to the axilla, and the claustrophrenic and the cardiophrenic angles are blunt. So what do you make of it? This is a classical case of left-sided pleural effusion with mediastinal shifting. Very important to mention this in diagnosis. Very commonly given X-ray. So you need to think of mediastinal shift. Of course, the clues of picking up a pleural effusion are obliterated or hazy angles of the claustrophrenic angle and the cardiophrenic angle. The diaphragm is not being seen properly. It is because there is intervening media, and this fluid level is very much classical of pleural effusion. It is not a straight air fluid level as seen as hydropneumothorax. So this is not hydropneumothorax. This is a pleural effusion. Of course, this is normal lung field, so there is no question of pneumothorax. Very commonly given X-ray. Let us see another example. So almost we are not going to discuss every time the ABCDEF approach, but that should be your approach anytime you see an X-ray. So you can see that the angles, the right-sided claustrophrenic angle and the left and the right cardiophrenic angle, these are blunt. The diaphragm is not being seen properly. There is homogeneous opacity in the right lower zone. Can I say that? Right lower zone homogeneous opacity with a meniscus like upper border of the opacity with its highest border reaching somewhere at the axilla. So, and you need to see that where is the trachea, right? The trachea is somewhat pulled to the right side. The mediastinum has not shifted. So, probably there is some underlying pulling lesion also. Usually a pleural effusion, it pushes to the opposite side, but it has not done so. Maybe there is an underlying collapse. So it is not that every time you will be having a single pathology. So this is a right-sided pleural effusion. with mediastinal shift to the same side, right, to the right side, if I can say so. So this is again an important X-ray of pleural effusion on the right side. Now let us see these two X-rays again. Initially, if you look at this X-ray, this looks almost very a normal X-ray, but if we go by the approach of A, B, C, D, E, F, in the E part, to catch effusion, we will be seeing these angles, and well, you can say that the right-sided costophrenic angle is blunt. That means it has got some fluid here, so which is definitely a pleural effusion. So you need to be, it is not always that your x-rays will be very much obvious, but this is the way to see pleural effusion. There is no mediastinal shifting and the diaphragm is more or less seen on the both side. See this x-ray. This is again another X-ray of pleural effusion, and see the mediastinal shifting, the degree of mediastinal shift. The cardiac silhouette has been shifted to the right side. This is also a left-sided pleural effusion. It has reached almost the second or the third rib, so it is a massive pleural effusion. Massive pleural effusion, which is if the pleural fluid is more than 1500 or it has reached up to the second ICS. It has got a mediastinal shifting, very important. And why this, the level of the pleural effusion is having a highest border at the axilla? This is a radiological illusion. This is not a real thing. Actually, it is having a horizontal level everywhere. So for example, if this is your level of, let's say, the fourth or the fifth rib, the entire thing is at this level, but during the x-rays, the x-ray beam cannot pass through the axilla. As a result, the opacity is kind of seen more as an illusion in the axilla. It is also known as the Ellis S-shaped curve. It is a radiological illusion, and it is also a clue that this is a pleural effusion and not anything else. In reality, the level of fluid is a horizontal level of fluid, right? So we have seen almost every X-rays of pleural effusion. So whenever you are given or whenever you think that this is an X-ray of pleural effusion, divide it into two, that with mediastinal shift away from effusion or towards effusion. Many a times there might not be any mediastinal shift like in this case. So that is an important thing. And for clinical detection of fluid, clinically if you want, then it is 500 ml. If you want to detect fluid by x-rays, then you have to have a fluid of somewhere 200 to 250. In lateral decubitus film, where the patient is lying like this on the x-ray plate and the x-ray beam are coming like this, so you can have a fluid, you can detect as little as 25 ml of fluid. In USG, it is exactly double. These are approximate amount of the fluid you can detect by these three modalities: X-ray PA view, lateral decubitus view, and USG. So the important point is the meniscus of upper border of effusion, blunting of the costophrenic and the cardiophrenic angles. These are the very important points you need to know for detecting a pleural effusion on X-ray. Now, once you have detected a pleural effusion, you might be asked that what kind of fluid it is. How do you know? How can you know about that? So it can be a transudative fluid, right? It can be a transudative or it can be an exudative fluid. And how do we know that? By doing the Leitz criteria. This is the pleural effusion fluid, pleural fluid protein by the serum protein, pleural fluid LDH by serum LDH. Ratio if more than 0.5. If you know a bit of Hindi, patch is 5 and pleural effusion. So patch is 0.5 and the protein is also 0.5. So you can remember it like that, and LDH is 0.6. So more protein, more LDH, that means it is an exudative, that is there is inflammation taking place, it is an exudative. So 0.5, 0.6, Light's criteria, more than 0.5, more than 0.6. This is all about pleural effusion. Now let us see this X-ray. This is a test for you. So diagnose this X-ray by pausing this video for some time while I annotate the X-ray for you. This is the trachea dividing into the right and the left main bronchus. The right costophrenic angle is clear, the right cardiophrenic angle is clear. Right, the diaphragm on the left side is not at all seen. The costophrenic angle on the left side, cardiophrenic angle on the left side is blunted. So is this an X-ray of left-sided pleural effusion is my question. You can pause this video for some time and try to answer this question. Note that previously we were describing a fluid like this, fluid level like this. This is not looking like our previous fluid levels of pleural effusion. It is having a bulge towards the medial aspect, and the angle formed by this with the chest wall is an obtuse angle. This is the angle formed by the opacity with the chest wall, obtuse angle. Right. So what do you think this is? It's a homogeneous opacity. This is a classical X-ray of empyema, an important differential diagnosis with pleural effusion. You might be asked, how can I tell that? Just by seeing this obtuse angle formed by the chest wall with the opacity. This is the clue, and the border is having a convexity like this. It is somewhat a loculated thing, right? Because there is a lot of inflammatory exudate inside the pleural space, leading to this kind of shape. So this is an X-ray of empyema. Right. So that was all for this video. We will be discussing in the next video regarding collapse and consolidation as a whole. So till then, keep studying. Thank you everyone.